Welcome, everyone. My name is Vanderlene Kung. I'm a co-chair of the Renal Pathology Education and Training Committee. It is my pleasure to welcome everyone to today's GlomCom RPS joint webinar. We'll be continuing on the theme of digital image analysis and renal pathology, and our speaker today is Jeffrey Hodgin. And with that, welcome, Dr. Hodgin. Thank you for being here today.
Thank you very much for inviting me. Happy to hear someone read that 2010 paper.
It's a great paper.
Thank you. All right. Let me just get started then. So my title is Morpho-omic Integration and Clinical Deployment. I'm going to start with a lot on the morpho-omic integration and a little bit about the clinical deployment. These are my disclosures. I'll say, okay, so with digital pathology and image analysis, excuse me for a second. Yeah, okay. The goal is precision through data integration. At least that's my goal. So with data-driven patient categorization, identify new clinically relevant patient categories, use this technology for highly quantitative analysis, feature recognition, and even subvisual feature extraction, things that us pathologists think we can see, but perhaps can't. And we want to integrate this with the clinical data and the omics level data. And as you can see, here's the top-down or bottom-up phenotype to genotype figure that we often use from University of Michigan, highlighting all the different types of data, including pathology. And then, as I mentioned, we'll be talking about integrating it with the clinical. And then for me, the molecular, it's largely transcriptomic, but there are efforts to do it across the board there with other molecular modalities. And of course, once you can do this, this multi-scalar data integration, the hope is you can identify patient-level pathway activation, things, patient profiling to get an idea for outcome prediction or new drug treatments based on that, and even non-invasive surrogate markers. So the morpho-omic integration, we want to extend the landscape of the omics technologies here in this figure, like the genomics, transcriptomics, proteomics, metabolomics, just as I said, across the board with the structural analysis. And up to now, pathologists have been doing that in a qualitative or semi-quantitative manner. And we have the ability now to do so much more, even at an ultrastructural, microscopic, and macroscopic level. And this is kind of the way I see things as far as the digital pathology and image analysis. There's the quantitative morphology that we've been using in Neptune and other cohorts for quite some time. This would be the digital pathology scoring system. This is a bunch of pathologists get together and really score the heck out of the features in the glomeruli, tubular interstitium, et cetera. It's labor intensive, not something you can clinically deploy, but you get a lot of data. Now, digital pathology is crucial to be able to do that, to be able to share the images. But of course, we want to have computer-aided image analysis, such as the supervised deep learning, segmentation, and feature extraction, allowing you to get things like fractional interstitial area and size of the glomeruli, et cetera. And then on the right is the unsupervised deep learning neural network that I'm not going to be talking about. That's where you basically, throw images at the computer and tell it, say, these images are for patients that did well, these patients did poorly, and see if the computer can figure something out and predict that. But it's not very satisfactory because it doesn't give a lot of information about the structure and exactly what it's seeing, although there's some advances in that area, but that's not where we are yet. So a lot of you have seen these slides, the Precision Medicine for Glomerular Disease in Neptune, the Nephrotic Syndrome Study Network. We'll start there. It's a multi-center trial, 32 North American sites, capturing tons and tons of data, clinical data with outcome, 760 glomerular and tubular gene expression data sets, and histology and structural analysis, among other things. The sample procurement protocol being at the time of indication biopsy, an extra core is taken, microdissected for the glomeruli or the tubular compartment, and then you get molecular phenotyping, RNA sequencing for the most part. So this is what we've been doing for more than 10 years. And of course, that's changing now with the advent of single-cell, single-nucleus technologies. But we have a lot of data here, and there's still a lot of use to this type of approach.